Hi, this is Jessica Spies, one of the staff dermatopathologists at CTA lab. And today I'm going to be doing, for the resident lecture, 18 unknowns, and they are not related to the last two chapters in Lever because the last two chapters we did in Lever were so lightweight, so to speak. And so I've actually pulled about 18 cases that are from all over the book. And but going forward, we're going to have some meatier Lever chapters where we have the 3 weeks of the month are going to be covering chapters, and then the last week of the month is going to be unknowns from those 3 chapters. So that today's a little bit of an exception. So let's just get started. This is unknown number 1, and I hope all of you got to view the unknowns before listening to me go over these. But let's just dive in right here. This is, you can see a skin punch with a large amount of subcutis in it, and in the deep subcutis, there is something going on in the fat here. And if we go a little bit closer, we can see it's a proliferation of these very bland spindled cells, sometimes in what we call a parallel array, and they're mixed in between these mature adipocytes. And then they also are admixed with this collagen that we describe as a ropey collagen. That's another buzzword for this entity. So it's a spindle cell tumor, bland spindle cells, ropey collagen, parallel arrays, admixed with mature adipocytes. This is a spindle cell lipoma. This sometimes can have a myxoid stroma. We don't really see that here. Spindle cell lipoma is now lumped in with pleomorphic lipoma because of common cytogenetic abnormalities. And so you may see tumors that look a little bit like this, but have larger multinucleate giant cells or floret cells, and some smaller round dark cells. Actually, these are just lymphocytes here in this one. So what you want to make sure is this is not some kind of liposarcoma. There are no or rare lipoblasts in these tumors. There's no prominent vascularity, and very rare mitotic figures, if any, and no tumor necrosis. This was the posterior neck mass of a 63-year-old male. That's a typical clinical you get with these tumors. 10% of them are on the posterior neck or shoulder. 90% are in men, although they may present anywhere, and I have seen them all over the body. Okay, so that was unknown number 1. Let's go to unknown number 2. All right, unknown number 2 was the lip of a 52-year-old female. And you can see we have a nice punch biopsy that includes skeletal muscle down here. This is not a tumor. This is normal for site skeletal muscle. And we know it's skeletal muscle because you can see these striations, and then the nuclei in the muscle cells are peripherally located. And then you can see a pretty normal epidermis here. Lots and lots of solar elastosis, and then these big cystic-like spaces filled with this bluish material. It's kind of homogeneous looking, has these crisp edges. And this is lip filler. This is hyaluronic acid. In the old days, they used to use polyacrylamide also. Those are the 2 main fillers that are widely available, but polyacrylamide is really not being used anymore because of fears of granuloma formation, whereas the hyaluronic acid is much safer in that respect. So I thought this was kind of a fun one. Things that you might think about besides filler, if you didn't recognize this as foreign material, you might think about some kind of myxoid cyst, like a mucocele on the lip. but mucin doesn't have these kind of very crisp edges like this. It may sometimes have a little bit of a homogeneous appearance, and it can be eosinophilic besides being bluish or basophilic. All right, let's go to case number 3. All right, this is case number 3. And this was the shoulder of a 25-year-old female. And you can see we have a little punch biopsy of skin. And then the surgeon went deeper and dug this out in the subcutis. And you can see we have another proliferation of spindle cells in the subcutis. It's kind of fragmented here. Let's look a little closer at these spindled cells. They're pretty bland. Some of them have kind of small nucleoli, a little bit maybe vesicular nuclei. And if you look, it depends on the orientation of the fascicles. They're kind of arranged in fascicles here. But these have these kind of long, drawn out, tapered ends, these spindle cells do. And then in other areas, they have this kind of, what we call a tissue culture look or feathery growth pattern. Some extravasated red blood cells. If you thought that was artifact, there's extravasated red blood cells over here. The other thing about this entity is often there's kind of a zonated, what we call a zonated appearance to it. I'm not sure that I'm appreciated in this example exactly. But it tends to be more cellular centrally and more hypocellular peripherally. So this is nodular fasciitis. One thing I didn't mention is the stroma of this ranges from myxoid to collagenous, and in the older lesions it can be quite collagenous, so we've got a little bit of a collagenous stroma here. And then you can have areas of cystic degeneration, which I think is kind of this area here, what this is undergoing. Mitotic activity is not conspicuous in these lesions, but you can have mitoses. However, you won't have atypical mitotic figures. There can be scattered lymphocytes, histiocytes, and even osteoclast type giant cells, which I think, well, let's see here. We have maybe a giant cell here. Hard to say that it's osteoclast type. Oh, many giant cells here actually. Yeah, really nice. And we already talked about the extravasated erythrocytes. This is a benign self-limited neoplasm. We used to think it was reactive, but now we believe it's a neoplasm of fibroblastic or myofibroblastic derivation. Virtually all cases contain fusion genes. MYH9-USP6 is the most common fusion product, although there are other USP6 partners. There's a wide range of age involvement and anatomic distribution. All this is typical female shoulder, young patient. It mostly originates in the subcutis, but can also arise in the dermis, fascia, and skeletal muscle. All right, let's go to number 4. Okay, so this was palpable purpura on the leg of a 75-year-old patient. And you can see there isn't much epidermal change, excuse me. There's a normal Baskin weave strata corneum, kind of unremarkable epidermis. And then in the dermis, you can see it's kind of a busy look at low power. And if you look even closer, you can see around the vessels and in the interstitium, there's neutrophils. Let's see, there are lots here. These polymorphonuclear lymphocytes, they have these segmented nuclei. There are often eosinophils as well in these lesions. Not finding one right away, but you might find one. This is probably an eosinophil with this granular cytoplasm. We're not seeing the nucleus, the bilobe nucleus very well. Oh, it might be, here's another one probably. And lymphocytes, and there may be some histiocytes. And then you will see in the vessels fibrin, or even you may see fibrinoid necrosis. So this is, and extravasated red blood cells, excuse me. All these kind of refractile red pink blobs are red blood cells. So this is leukocytoclastic vasculitis, and the leukocytoclasis is the leukocytes that have been hanging around for a while. They start dying and their nuclei get split apart, and you get this what we call leukocytoclasis or karyorectic debris, nuclear debris. You may or may not have fibrinoid necrosis. The constellation of histologic features you find in LCV is dependent on when you biopsy it. It's really best to biopsy it between 18 and 24 hours of duration. And you can see here, actually, this is typical where you can't really see where the vessel is, especially at low power. You're like, I know there's supposed to be a vessel there, but we can't really see it because it's just obscured by this fibrin and all these extravasated red blood cells and inflammatory cells. You can see, as I said before, a variable number of eosinophils that may or may not represent drug reaction as an etiology. This is, as most of you know, a hypersensitivity vasculitis, so it has lots and lots of different etiologies, and we think of it as a reaction pattern in a way. Okay, let's go to the next case. Number 5. This is a pink papule on the shoulder of a 42-year-old female. And we've got a nice punch biopsy of skin here that's been bisected. I kind of like this section here for demonstrating all the features the best. At low power, you can see there isn't really any stratum corneum change. That's a normal basket-weave stratum corneum. And then this is probably a little bit more of the normal epidermis, but you can see in the middle of overlying this dermal tumor is epidermal acanthosis with these fused and blunted rete, and often there's increased pigmentation here too. You can see here some of these basilar keratinocytes have melanin in them. And in the subjacent dermis, we don't really have any subcutis in this biopsy, but this is a dermal-based neoplasm. You can see it's petering out down here before we get to the subcutis. It's a dermal-based neoplasm, and it's another spindle cell lesion. And they're relatively bland, but slightly pleomorphic spindled cells. And they're growing in what we call a little bit of a story-form pattern, where they have a little bit of a swirling growth pattern. And then at the very edges of the tumor, there are these collagen balls. So this, or we also call this peripheral collagen trapping. And these are all the typical features of a dermatofibroma. Actually, when I was first in training, we thought of this as reactive, because it often comes up after cutaneous injury, such as a prick from a thorn, vaccination, or an insect bite. Then it was shown to be clonal, and we all started thinking about DFs as being neoplastic. And I think now we're back to could be reactive, could be neoplastic. So I hope they don't ask you that question on your boards. I would probably go with neoplastic since it's clonal. But I think there's a little bit of not complete agreement about that. Okay, let's go to the next case. Number 6. Okay, for something different. Okay, So this was a flesh-colored firm plaque on the scalp of a 79-year-old male. And you can see here at low power, we have a pretty deep punch biopsy. There's some subcutis here, but look, whatever this process is going beyond the subcutis, and it has this kind of cookie cutter outline at low power. Let's go a little bit closer. And what's going on here at the dermal-epidermal junction? There is a proliferation of these cells with hyperchromatic nuclei. Some of them have a lot of eosinophilic cytoplasm. They're forming maybe small nests, but many, many, many single cells here. And then we have a loss of the reedy ridge pattern. We call that effacement of the reedy. And then some of these cells are scattering above the dermal epidermal junction, or we call that a pagetoid growth pattern. And here's some small nests. So even though this doesn't have pigment, I'll tell you this is melanoma in situ. And we can prove that with a number of different immunohistochemical stains, but SOX10 or S100 would be the best. Because these cells don't have pigment, they may not have melanosomes, and therefore an HMB45 or melanA probably won't stain them because those are melanosome stains. So let's go here to what's going on in this thickened dermis. So we've got melanoma in situ at the dermis, dermal epidermal junction, and then we have these cells that look a little bit different because they're more spindly, but some of them have still similar nuclei to those in the epidermis. And this is an invasive component. You can see some of them actually look a little bit histiocytic. And others have these really large atypical nuclei. Look at these here with giant nucleoli. And they're growing in these short fascicles between thickened collagen bundles. You can see here, down here, this is solar elastosis that's been pushed down from the superficial dermis into the deeper dermis by this neoplasm, by this melanoma. And here you can see in some areas, the cells can look quite bland, but in other areas, quite large. And then down here in the subcutis, they're going a little bit into the subcute fat, but really tracking down around the septae, deeper, deeper, deeper here. So I'm going to see if there are any lymphocyte aggregates. There are some lymphocyte aggregates maybe here. Oh yes, here. These are a clue to the diagnosis of desmoplastic melanoma, which is what this is at low power. If you see a spindle cell proliferation, because you don't always get a melanoma in situ component, if you see a spindle cell proliferation in the dermis and you have lymphocyte aggregates, think about desmoplastic melanoma. This is a real trap for dermatopathologists because there is often no melanoma in situ in the biopsy. So these may mimic a scar, they can mimic a dermatofibroma, other malignant spindle cell tumors. And as I said before, you want to use a SOX10 or S100 to highlight these cells. Now, this is a pure desmoplastic melanoma. There's no conventional melanoma component to it that we can see in this biopsy, and those have a better prognosis. They have a higher tendency for local recurrence, but metastasis to regional lymph nodes are less common than conventional melanoma. Okay, let's move on to number 7. Okay, and looks like I have misplaced the clinical that I gave you for this, but I believe it was the face of a middle-aged person. And you can see we have kind of an incisional biopsy here with relatively normal looking, excuse me, epidermis at low power. And then what's going on is all in the dermis. And you can see these nests and strands of or aggregates of basaloid cells, mostly strands, and then some squamous cysts, many filled with keratin, some calcified. Here's more calcification. You can see we're on sun-damaged skin here, so beware. And then if you look at these cells, they're relatively bland. If you look at the neighboring keratinocytes, they're really not much bigger or even the same size as the keratinocytes. We're not really seeing any mitotic activity, not any peripheral palisading or apoptotic tumor cells. And then if we look over here, I think there's an example where it's trying to make a hair bulb. So this is a desmoplastic trichoepithelioma. And I forgot, it sits in this collagenous stroma, that's the desmoplasia. Often you can see, even in the punch biopsy, clinically they will have a dell, and this is a little bit of dell here, where the tumor has, because of its desmoplastic stroma, has retracted almost the dermis down. As I said before, it's a hair follicle tumor, often in children, maybe familial, autosomal dominant related tumors are multiple, dome-shaped papules on the face, scalp, neck, and upper trunk. Brooks-Spiegler syndrome, familial cylindromatosis, and multiple familial trichoepitheliomas are due to germline mutations in the cylindromatosis or CYLD gene on chromosome 16q12, which is a tumor suppressor gene. And as I said before, autosomal dominant inheritance. So those will be some board questions for sure. What syndromes do you see this tumor in? The differential diagnosis, histology, and this is something we deal with fairly frequently in just normal everyday sign out, is a low-grade basal cell carcinoma, serongoma, and microcystic adnexal carcinoma, excuse me. So for basal cell carcinoma, there's a low-grade or infundibulocystic pattern basal cell carcinoma. You will see more apoptotic cells, possibly mitotic cells. You won't see this good this primitive follicular differentiation is called a papillary mesenchymal body. Basal cells, or BCCs, are not differentiated enough to do that. And so this is really a great clue to the fact that you're dealing with benign adnexal follicular tumor. Serongomas have more duct formation, and they tend to have more of the tumor tends to look like this, and often these little ducts have the epithelium surrounding them have this kind of tail, so they look like tadpoles. Microcystic adnexal tumor can be very difficult when superficially sampled. It can be very low grade cytologically, and really can be difficult to diagnose until you see the bottom of the tumor, where you're going to see these duct-like structures lined by really, really bland epithelium just diving into the deep dermis. So it doesn't have this nice kind of circumscribed look to it. All right. Let's go to the next case, number 8. Okay. So you're wondering, what is this doing in a derm path study set? Because we have no skin here. And this is actually a subcutaneous process. And it has these nodules, very circumscribed nodules, of, again, a little bit spindly cells, some more ovoid, many giant cells interspersed here, some siderophages. This golden refractile, these globules are hemosiderin. Melanin tends to have a more chocolate brown and less refractile appearance. Lots and lots of giant cells, which is a clue to the diagnosis. This is a tenosynovial, giant cell tumor or giant cell tumor of the tendon sheath. And the clinical was slowly growing mass of a thumb in a 35-year-old male. That's a typical history that we get for these. Kind of like dermatofibroma, they were originally believed to be reactive, but are now considered neoplastic. We do get these occasionally in our practice, and this could be on your boards, this entity. Other things that you might see in this tumor besides these little banal and a little bit spindled cells are the giant cells. You can see foamy macrophages, which are not really that great in this particular tumor. Not really seeing that. Well, maybe this is a little bit foamy here, kind of hard to say. As I said before, they're now considered to be a neoplastic. Surgical excision is usually curative, but these may recur. All right, let's go to the next case. Number 9. Okay, so we're halfway through after this one. And this is an index finger mass in a 75-year-old male. So you can see we're on acral skin, where we have this thick stratum corneum composed of orthokeratosis with a thickened granular layer. But really the action here, once again, is in the dermis. And you can see there's this kind of bluish material admixed with these spindled cells. And then here at the edges, there are some giant cells. So maybe more giant cells. Most of these are actually histiocytes. And then if you look at the material, so histiocytes surrounding this kind of bluish, sometimes pinkish material, we look a little bit more closely and we can see it's fibrillar. This is a gouty tophus. And, excuse me. So these tophi are composed of needle-shaped aggregates of urate crystals with surrounding foreign body giant cell reactions. So this is not a neoplasm. All of these spindled cells are histiocytes, and they're just reactive inflammatory cells. The urate crystals typically dissolve in routine processing, but more often than not, we'll actually see that you can see here that these have dissolved in the middle, but more often than not, we'll get some residual crystals and we're able to make the diagnosis on H&E. The books say that under polarized light microscopy, they have needle-like morphology and a strong negative birefringence. The differential diagnosis for their appearance is pseudo-gout or calcium pyrophosphate disease, but that is basically rarely encountered in the skin and doesn't form tophi. So when you see this appearance, you know in the skin, you know that it's gout, and you don't really need to do the polarization to make the diagnosis. Okay, next case, number 10. Okay, so something a little bit different. This is a cystic mass on the right eyelid margin of a 15-year-old female. And you can see here that we don't have normal epidermis here. We have kind of a pseudostratified epithelium with these goblet cells. These are not malignant pagetoid cells. These are goblet cells, normal for sight. This is the conjunctival epithelium. So remember, we're on eyelid margin. And then we might be right on the margin here because this looks like it's probably a little vellus hair follicle. And then actually here we have a nice hair follicle looking straight up at us with its hair shaft and associated sebaceous glands. So cystic mass here is part of it, and here's the rest of it in the second piece of tissue. And it is indeed a cyst lined by this very bland epithelial, by these very bland epithelial cells. And what's distinctive about this lesion is it has this, not a granular layer like you'd see in a normal epidermal inclusion cyst, and not the ballooning keratinocytes of a pilar cyst, but a corrugated cuticle. So no granular layer, this pink, and if you look at it under the microscope, and I think you can appreciate it a little bit here, it has kind of a very refractile appearance. And then it's often filled with keratin and often has sebaceous glands in its wall. It's not very well demonstrated here, but over here, we've got sebaceous glands in the wall. They can be ruptured and have a granulomatous host response. This is a steatocystoma. So I've just described all the pertinent histologic features. Really, what's going to tip you off to the diagnosis is this corrugated cuticle. That's what you want to see. And then it's nice if you see the sebaceous glands in the wall. So these can be solitary or they can be multiple. And when they're multiple, it's steatocystoma multiplex. Some people call them sebaceous duct cysts also. They can arise sporadically or with an autosomal dominant pattern of inheritance. Rare cases are associated with Gardner syndrome, pachyonychia congenita, and ectodermal dysplasia. Okay, so that's cute. Let's go to the next case. Number 11. And this was a right inframammary white plaque in a 50-year-old female. And you can see here, we have a little bit of normal basket stratum corneum, some compact orthokeratosis, a relatively normal looking epidermis, except that it's floating off the top of the dermis here in this punch biopsy. Around hair bearing skin here, here's a follicle. And then if you look, actually, here's a little bit of dermis, papillary dermis attached here to the epidermis. If you look at this papillary dermis, it has this pink, focally edematous, but also what we call a homogenized appearance. And that is a buzzword for the homogenized collagen for lichen sclerosis. So this is extragenital lichen sclerosis because it's inframammary. Depending on the age of the lesion, you may or may not have inflammatory cells. You can see here, this is relatively advanced because in the early lichen sclerosis, you will have a lichenoid interface dermatitis. But it's really in the later stages when you get this homogenized collagen that you can make the definitive diagnosis. And you can see that this collagen change has pushed the inflammatory cells down into the deeper dermis here. There are lymphocytes, sometimes histiocytes, and not infrequently eosinophils, if any of you found eosinophils in this, that's quite common in this disease. You can have this type of looking superficial epidermis also in morphia scleroderma, but we don't have the deep dermal collagen changes for that in our biopsy. So just to know, extragenital lichen sclerosis affects 10% of women with the vulvar disease. So always when you get that diagnosis back, look at the vulva in a woman. It's 10 times more common in women than in men. And it is associated with a personal or family history of another autoimmune disease, such as thyroid disease, often pernicious anemia or alopecia areata. We don't entirely understand what causes LS yet, but many people consider it an autoimmune disease. Okay. Let's go. You can get this kind of, before I leave this case, you can get this kind of homogenized collagen in a scar also, but you won't have this lichenoid infiltrate here. This is this kind of trifecta of the homogenized collagen and pushing the inflammatory cells down, and the effacement of the radii, I forgot to mention that, is typical of LS. And so this kind of low power view is not one of a scar. Number 12, okay. This was a 63-year-old female with a history of breast carcinoma, left breast plaque. And we've got a punch biopsy. We'll start from the top here, a little bit of normal basket weave stratum corneum, some hypergranulosis and epidermal acanthosis. Probably a slightly increased number of vessels, but mainly I think they're just dilated. So we've got telangiectasia, we've got some extravasated red blood cells, and then what have we here? Look at this cell. Compared to a keratinocyte, this is probably 5 times the size, has this enormous nucleolus, has a little bit of pink cytoplasm, and it does have this kind of drawn out looking cytoplasm, like we saw in our nodular fasciitis case here again. So this is a fibroblastic cell. And it's set in this morphia looking, this smudgy pink collagenous background. So this is chronic radiation dermatitis. And that is the constellation of features. We see that dilated vessels or telangiectasia, the radiation, we call these radiation fibroblasts, in this fibrotic morphia-like background. The onset of chronic radiation dermatitis can occur from 15 days to 10 years or more after the beginning of radiation therapy. So it's important to get a good clinical history. And I think that's it for that case. It's kind of we don't see this very often, but we do see it. And these radiation fibroblasts are really the key. And they will always be low density. If you see, you know, solid aggregates of these cells, then you're probably dealing with a malignancy. All right, let's go to the next case, number 13. I didn't realize till after I picked all my cases that it was going to be kind of a spindle cell day. These came from our archives, so I don't have all the special stains. Excuse me, some of these cases are many years old and the slides are in storage, so I couldn't get them fast enough to show you mucin stains and things like that. But we have the H&Es, okay. And the clinicals, which is really helpful. All right, so this is a 52-year-old female with thyroid disease. And you can see we have a relatively normal basket weave stratum corneum and epidermis. And then what's going on in the dermis, it doesn't look entirely normal. It's, first of all, not very pink like a normal dermis. It's got these kind of delicate collagen bundles, not really fibrotic, with huge amounts of space in between. And then very kind of bland looking fibroblasts here with the long drawn out tails. And if we stained this with a colloidal iron stain, this was all turned blue. This is all mucin. So this is pretibial myxedema or thyroid dermopathy. Unlike scleromyxedema, you're not going to get the increased numbers of fibroblasts and the background dermal fibrosis. This mucin that we stain is due to the accumulation of mucopolysaccharides in the dermis, which is also what happens in the orbital tissues caused when you have excess TSH secretion or hypothyroidism. Okay, let's go to the next case. Number 14. And the clinical I gave you was a 30-year-old male on the upper back. And again, we're in the spindle cell category. We can see we have a relatively normal stratum corneum and epidermis. And then we have this not entirely circumscribed, but kind of well circumscribed, nodular, I guess I would say, proliferation of spindled cells. Let's look a little bit more closely. The spindled cells are slightly pleomorphic, but there are no really atypical looking forms, nothing like that radiation fibroblast we saw. And they're arranged in these long sweeping fascicles. Some are coming out at us here, so we see the cells in cross section. And then if we look at the edges here, I mean, I suppose you could call this infiltrative, but really, I don't think this is particularly infiltrative. You can kind of see that the tumor ends suddenly here. If we had the whole tumor out in an excision, we'd probably appreciate that better. So this is a leiomyoma. And if you did a Desmond stain, it would light up these cells. It would just be black with the immunohistochemical staining. You could also do smooth muscle actin, but I think in my experience, Desmond works more reliably. And there are lots of other spindle cell tumors that can stain with smooth muscle actin. So I like Desmond better for this diagnosis. The differential diagnosis is cutaneous leiomyosarcoma, which we don't call leiomyosarcoma anymore because we know when it's based in the dermis that it behaves in a relatively benign fashion if it's completely excised. And so we call those atypical smooth muscle tumors now. And in a cutaneous, or I'm sorry, there I go again saying leiomyosarcoma. In an atypical smooth muscle tumor, what you'll see is, you'll see something like this. It can be more infiltrative looking. You'll have more atypical hyperchromatic nuclei, maybe not every one, but it'll catch your eye more at low power. And then you'll have an increased number of mitotic figures. All right, let's go to the next case. That was 14. What I did want to mention about cutaneous leiomyoma is that almost all patients with multiple skin leiomyomas have a germline mutation in the fumarate hydratase gene, which is a tumor suppressor gene implicated in hereditary leiomyomatosis and renal cell cancer syndrome. And that could definitely be a board's question. All right. Number 15 was a 17-year-old female with red-brown patches on her bilateral lower legs. Okay, now pivoting away from neoplasms, we have what looks like a dermatitis. So I've got a relatively normal stratum corneum, so you wouldn't have seen scale clinically. Maybe a tiny bit of spongiosis here, but an otherwise kind of untouched epidermis. And in the dermis, we have this superficial and mid-dermal, perivascular, some interstitial, but mostly perivascular infiltrate of lymphocytes with extravasated red blood cells. They're these refractile red-pink blobs again. And the first thing you might want to think about is leukocytoclastic vasculitis. The clinical is not palpable purpura, but let's look at the vessels anyway, and you can see we have a pretty normal looking vessel, not that fibrin deposition and fibrinoid necrosis we saw in our leukocytoclastic vasculitis biopsy. And this is pigmented purpuric dermatitis. As the lesion ages, the histiocytes will come in and start gobbling up the red blood cells, and you get these siderophages. It's kind of hard to tell sometimes that these are siderophages, and you might think they're melanophages. You can do a Pearl's iron stain, and that'll turn them bright blue. Over here, you can see this is a little bit more typical of the H&E appearance of hemosiderin. It has that kind of globular refractile appearance. And in early lesions, you might not have the hemosiderin if you biopsy a really, really early lesion. Here's some really good extravasated red blood cells here. People have called this a pseudovasculitis or lymphocytic vasculitis, but it's not a true LCV. The different variants of capillaritis or pigmented purpuric dermatitis you should know for your boards. In terms of the histology, they all look similar pretty much, all the clinical variants except for lichen aureus. And in lichen aureus, you have a very distinctive histologic picture. And sorry, this is an example, but you'll see a band-like infiltrate of large numbers of siderophages, and that's what gives you the golden or aureus color clinically. So other things you might think about for this biopsy with the purpura would be a drug eruption. We have already ruled out vasculitis. Maybe a spongiotic dermatitis on the leg in which the red blood cell extravasation is physiologic rather than pathologic. When we biopsy the lower legs, especially older patients, you often get a lot of extravasation of red blood cells, and that doesn't mean that it's pigmented purpuric dermatitis or that it's leukocytoclastic vasculitis, so just be careful. All right. Let's go on to number 16. This was the chest of a 55-year-old female. And we have a nice big shave biopsy here. Red, kind of untouched stratum corneum out here, but here we've got some hyperkeratosis composed mostly of compact orthokeratosis. This is a little lichen simplex chronicus with its hypergranulosis and epidermal acanthosis. So this looks a little bit like acral skin. So when you see it on a hair-bearing, like here we have a follicle with its sebaceous glands, hair-bearing skin, that's the hairy palm sign. That's lichen simplex chronicus. Okay, but that's not what the diagnosis is here, because we've got something going on in the dermis. And again, more spindle cells, very small spindle cells with lots of space in between them. And really the collagen is mostly gone here. And once again, sorry, I don't have the colloidal iron stain to show you, but this is all mucin. So This could be focal mucinosis, or it could be a cutaneous myxoma. And this was signed out as a cutaneous myxoma. These often have small vessels within them, like we say here and here. And so superficial angiomyxoma, cutaneous myxoma, and focal mucinosis kind of overlap in their histologic features. These cutaneous myxomas, which some people put superficial angiomyxoma in that as a subcategory of that, are rare tumors which may be solitary or associated with a systemic syndrome. Carney's complex, which of course you know involves cardiac myxomas, body cutaneous pigmentation, and endocrine overactivity. Carney's complex is due to mutation in the PRKAR1 gene, which is another tumor suppressor gene with autosomal dominant transmission. So that is probably going to be a board's question. So just know that. And I guess other things you might think about for this. I mean, this is pretty distinctive histology, or maybe other things like a nerve sheath tumor, excuse me. We don't really have the cellularity for that. And lots of different tumors can have myxoid stromal change, including myxoid neurofibroma, which would be another thing with really bland spindle cells and sitting in a myxoid stroma. And you would do an S100 stain to differentiate between cutaneous myxoma and myxoid neurofibroma. The neurofibroma will be S100 positive. There's a little scar here as well. Many of you may have noticed here, just kind of interesting. We don't always see that with cutaneous myxoma, but there it is. All right, number 17. It's another punch biopsy of skin with another pretty normal looking stratum corneum and epidermis. This patient may be darkly pigmented. There's quite a bit of melanin here. You can see the keratinocytes with the little hats of melanin along the basal layer here. And then what's going on in the dermis? So we've got collections of lymphocytes around the vessels. And then in between these collections of lymphocytes in the interstitium, we have lots and lots of histiocytes, and some of them palisaded. This is palisading here. There's another area where they're palisaded around this altered collagen, or what we call necrobiotic collagen. And this is granuloma annulare. Oh, and here's some giant cells, which are very commonly seen. Also very common eosinophils. If you did a colloidal iron stain, this would light up as bright blue, and then you have your diagnosis. Other things you might think about: necrobiosis lipoidica diabeticorum, or NLD. It tends to be associated with more fibrosis rather than this necrobiotic collagen. And when you do a mucin or colloidal iron stain on it, it will not light up the same way that GA does. So it also tends to have more of a layer cake appearance. And I kind of would need to show you one side by side to show you that this is not what we typically call a layer cake. You see the kind of aggregates of lymphocytes squished between the fibrotic collagen more. The books talk about plasma cells being more common in NLD, but I often see plasma cells in granuloma annulare. So that is not, and if you found some in here, that does not exclude GA. Of course, you know GA is a hypersensitivity reaction, a delayed type of hypersensitivity reaction. And it has been associated with many systemic conditions, including autoimmune thyroiditis, diabetes, hyperlipidemia, and rarely with lymphoma, HIV, and solid tumors. Okay. Oh, sorry, wrong link. Let's go to number 18, and this is my last case. All right, we have another punch biopsy and not a tumor. Okay, so we've got some papillary dermal edema here with subepidermal vesiculation, perivascular inflammatory cells, and then what do we have over here? Collections of neutrophils in the dermal papilla. And I love when I see this because I read DIFs every day, and I usually get an H&E with the DIF, or I hope to get an H&E. And it's so nice when you get the histology to go along with the diff because you don't always get it. But this is dermatitis herpetiformis. There's not much else that looks like this. And of course, the diffs will show deposition of IgA concentrated in the dermal papilla, although I've seen some cases where it's almost linear granular IgA all the way along the dermal epidermal junction. And then you may or may not see some C3 deposited here also on the diff. DH doesn't always show diagnostic histology on the H&E, and I have had many cases where it's more of a non-specific histology, maybe superficial perivascular with a few eosinophils, and then I'm surprised the DIF is positive. So don't let, if you do an H&E biopsy and you don't get DH back as a diagnosis, but you still think it's DH, do a diff. What do I want to say about DH? Last case here, of course, DH and celiac disease due to intolerance of the gliadin fraction of gluten found in wheat, rye, and barley. Gluten triggers the production of IgA antibodies and an autoimmune process that targets the skin and gut results. The majority, or over 90% of patients with DH also have gluten-sensitive enteropathy. The GI symptoms may be mild or severe. Some patients remain symptom-free. And then about 15 to 25% of celiac patients have concurrent DH. And these patients in particular tend to have a more severe intestinal pathology in comparison to those without DH. And then the genetic predisposition is an association with HLA DQ2 and DQ8. Okay, so I hope you've enjoyed these cases. I took all of them except for the lip filler, which I just threw in for fun, from a list of need to know for boards entities. So even though we don't see all of these in everyday practice, your derm path portion of your derm boards is going to be pretty challenging. They're going to have difficult cases on it. Some of these were pretty straightforward, others a little bit more difficult. And we will see you next Sunday. All right. Thanks and have a good weekend.